Caring for Kids God's Way, a biblical counseling certificate program in child advocacy developed by the American Association of Christian Counselors through Light University. Your ministry is to be a Galatians 6:2 helper. Ours is to equip you with the highest level of advanced training from the world's leading Christian counselors. 24 experts teaming up to create the most comprehensive child studies curriculum for the personal classroom. May the Lord bless your study as you begin caring for kids God's way. Director of ARC Psychiatric Services in Atlanta and a frequent contributor to Christian Counseling Today magazine, Caring for Kids God's Way presents Dr. Glenn Havens, ADHD and Proper Intervention.
Most people don't understand that attention deficit is not really a deficit of attention. Most people instinctively think of a deficit as something that is not really, or you don't have what you need. Attention deficit would be better called attention regulation, because as most parents know, when a child is over-involved, and I hear this all the time, then they are difficult to pull away from whatever they're involved in. For example, on a video screen or a video game, the parents will come up and say, well, if the kid really likes it, then he will be so involved that I can't get him away from it. And what parents don't really understand is that it's just as difficult for a child to disengage when they are over-engaged as it is for them to engage in something that they very much want them to be engaged in, like homework, or over-focused, perhaps maybe a better word for it. Before we move on, I'd like to say something about the theology that I think is behind the whole idea of mental health in the Christian community. Most of what we'll be talking about today is purely neurologic, but there are always spiritual overtones. And I think parents struggle many times with what do you do with a child in the church who cannot fit into the setting? And we see this a lot of time with attention regulation disorders, and there's a whole family of them, which I'll talk about shortly. From my standpoint, the fall affected many people in many different ways. If you want to be consistent theologically, then you have to look at, for instance, the physical side of the fall. And we know that people are affected with physical illnesses. We know that sometimes it's their fault, sometimes it's their parents' faults, and sometimes it is because God chooses a certain illness for a certain reason. I think that everyone has a different share of the effects of the fall, and mental problems and emotional problems fall into their own particular category. So as some people have more physical problems than others, some people have more emotional or as we call mental problems than other people. One of these certainly is attention deficit disorder, and we call it attention deficit disorder. It's actually called attention deficit slash hyperactivity disorder. Interestingly enough, with or without hyperactivity. One thing that we can say for certain at this point is that it is a neurologic condition, that it is something that by and large is inherited or passed down genetically from one or both parents. There are other things that can cause attention problems that can be caused by strep throat and high fevers or brain injury, but that may be 5% or less of the cases. Predominantly, what we find is a genetic predisposition. Now, there is good evidence to show that it's more than one gene. And so perhaps there is a clump of maybe up to 4,000 or 5,000 genes that are inherited. And depending on how these genes are turned off or on, and in what combination, the outside can look very different. So in many cases, what we see is what we call attention deficit hyperactivity disorder. In other cases, what we see is obsessive compulsive disorder. And I'll talk about that shortly. One thing we can say for sure is that this is not an insignificant problem. It affects cognition and it affects behavior in highly significant ways. Many of these children have trouble with self-esteem, with performance, and as they grow into adults, they have trouble with relationships, they have trouble at work, and they have trouble with themselves. There are many common questions, and I'd like to cover those at first. A common criticism is that this is overdiagnosed. It's a good question. Doesn't everybody have this to some extent? Well, I think we can say that everybody has trouble paying attention from time to time. If you're tired, or if you're overworked, or if you're upset, you may have trouble paying attention. But this is not something that you find consistently, that you find day in and day out in all different parts of life. So the real question is, do we find problems with attention across the board in all different areas? Is it underdiagnosed or overdiagnosed? Well, it's probably both. I see this all the time, that people come in and they say, well, I think maybe I have ADD, or more frequently, I will see a child or an adolescent, and as I begin the interview and start going through questions, I find that one or both of the parents is going, oh yeah, gee, that sounds like me. So many times I end up with not only children, but also treating one or both of the parents. Is ADD more prevalent than it's been in the past? Well, I don't think so. I think what has happened is that we are much more sophisticated diagnostically, and we know more what we're looking at. For example, the classic stereotype of a child is a 6 to 9-year-old little boy who is lighting fires in the school and flunking out, as well as running all over the place. Now, in children, the diagnosis is something like 6 to 1 boys to girls, but in adults, it's more 50-50 for men and women. And the reason for that is that women and girls tend to be more the inattentive form of it without hyperactivity. They have nicknames like Space Cadet or Airhead, but girls, as we all know generally, are more socially well-behaved than boys. And so many times the girls will fall through the cracks and not be treated. They will underperform. Another frequent criticism is that this is a designer disease of the 90s, or that it's a minor psychiatric illness. Now, when I went through training, what I was told was that you at least outgrew it by early adulthood. And even if you didn't, that medications didn't work when you reached adolescence. So no one was treated after late childhood. Now we know that that's simply not true. Adults respond just as well to medication as children do. And as we all know, probably the best thing you can do for your children is to get your own act together. The history of the different names for this neurologic problem help us understand how difficult it has been to come up with a name that describes something that changes so much. I think in the very beginning we were probably right on target because it was called minimal brain dysfunction. So everyone's instinct was that there's something wrong somewhere in the brain, we just couldn't figure out what it is. Now the name has changed throughout the years. There have been many different names for it. Currently, as I said before, it is attention deficit / hyperactivity disorder, oddly enough, with or without hyperactivity. The hyperactive part tends to subside as you get older, and so what you find is primarily a lot of itch and wiggle or restlessness or a sense of not being able to sit still through something that you're not really focused on. It's very important to understand that this is at core a neurologic disorder and that there are a spectrum of different disorders that are very closely related. And what I mean by that is that when you find someone with attention problems in the family, you very often, and more than you would expect statistically from the general population, you will find someone with obsessive compulsive disorder, with Tourette's disorder, with a mood disorder that we're currently calling bipolar, although it probably isn't in nearly as many cases as it's been called that, and even autism and Asperger's, which is a higher form or higher functioning form of autism, are all very closely grouped together. So when someone comes to my office and they're talking about attention problems, I'm thinking about this whole spectrum of closely related disorders. Then you add to that it is also very common to have a tremendous amount of anxiety and often depression along with it. We're very fortunate in this time in medical history to be able to actually image the brain. We have a lot of research going on looking at not only what the brain looks like, and that's called structure, but also how the brain works, and that's called function. There are three kinds of scans that help us understand this. One is a PET scan, which many people are familiar with. Another is an fMRI, and that means a functional MRI. Most people understand that you have a CAT scan, and if that doesn't show you what you need, then you're going to step up one to an MRI. An MRI is structure, but a functional MRI shows how the brain actually spends energy. Another one that is very well known is the SPECT, S-P-E-C-T, and the SPECT scan also shows how the brain is spending energy. So we're actually able to look at the brain now and see that, for example, in ADD, that the frontal lobes are underperforming. Let's talk about the core symptoms. As you'll see on the slides, there are three primary symptoms. The first one is distractibility. Distractibility can be internal or external. Internal distractibility is distractibility by your own thoughts. For example, you're in the middle of a conversation and all of a sudden you realize that you didn't hear the last three sentences because you had so many thoughts going through your head. Or it can be external. External means you hear the birds out the window, or someone coughs, or someone moves, and then all of a sudden you realize you've lost part of what has been said. The second core symptom is impulsivity. Now, impulsivity is something that I think of as putting the ball in motion before you look to see which end of the court that you're throwing it at. Most people understand that when you put a ball in motion, when you put it in the air, then as long as it's in the air, the game is still going. So for a lot of people with ADD, they put the ball in motion before they look to see where they should throw it. As a result, they end up in the middle of a behavior before they've begun to think about it. Impulsivity can be verbal, and most of us as parents are very familiar with adolescent verbal impulsivity, also known as shooting off your mouth. But people with ADD tend to have a lot more trouble with that because as the thought crosses their mind, it comes straight out their mouth. So many times it feels like they're butting in or they're more preoccupied with what they have to say than with what the people around them are saying. But most of it with ADD is that if they don't say it when they're thinking it, they're going to forget the thought that they had that they wanted to express. Impulsivity can be through changing your plans. For example, on your way home from school, they end up doing 17 different things and never getting anything done that they started out to do. It can be physical, getting into fights many times. It can be sexual, and we see a lot of this with adolescents, that they're, anyway, it's a struggle, that they're in the middle of behaviors before they're able to think about them. The third core symptom is hyperactivity. Now, I would prefer to describe that more as a motor restlessness because many people are not hyperactive, and there are certainly forms of ADD that do not have any impulsivity or any hyperactivity. The other thing about it is that by the time you get to adolescence, the running around part of it tends to settle out, so that what you find in adolescents and adults is that they're very restless. So if they're sitting still in one place, you see their legs are tapping or they're shifting. It's like if they sit too long in one spot without moving, they're just going to explode. And they will say to me, it's sort of like having ants in your pants. Although sometimes you have people who that little motor is always running. I have one lady who her husband describes her as always standing up, even when she's sitting down. Now, these core symptoms vary, and I think that that is something people misunderstand. Sometimes they're more severe, sometimes they're less severe. Sometimes one predominates over the other. So the hallmark is inconsistency. And so what we see in these children, adolescents, and adults is massive inconsistency. They're very unpredictable, and though they may do very well one day in one subject or one task, then they'll turn right around the next day and do poorly at it. Now, this really frustrates children and adolescents in school because they can't predict success. Because if they do well in a subject one day, they may turn right around and flunk that same subject the next day. So it gives a lot of anxiety so that they're always waiting for the next shoe to fall. It's not a matter of if, it's just a matter of when. One thing that needs to be, and I need to point out right now, is that there is also a very common, in my opinion, learning disability that goes along with ADD. Not in every case, but probably 85–90% of the people that I see, children, adolescents, and adults, have a learning disability in the area of organization. This is known as executive dysfunction. So that not only are they distractible, they're also organizational disaster areas. Their rooms are a mess, they're given a list of tasks to do and they can't follow through. They may do the homework and not turn it in the next day. They can't plan ahead and sequence. They can't feel the movement of time inside of them. So when they need to be someplace, they will have 15 minutes till they leave, and they'll pick something to do that takes 17 minutes. So they're late getting out the door. Many people can feel time as it moves. So if there's 15 minutes, they know relatively when 15 minutes is up. Most people with the executive dysfunction do not feel the movement of time. So depending on how involved they are in a task, they may feel like only a minute has passed and it could be an hour. Now, what does it look like on the outside? When parents sometimes when children are sitting with parents, but when parents are sitting with their children or their adolescents, what does it look like from the outside? I have a list of things on a slide for you. Parents pick up the slack. Hear this over and over again, that the parents have to get in and organize them and keep them on task. They often have meltdowns, and when they have these meltdowns, they don't remember what's said. Everyone else remembers what's said because it's very painful, but they actually can't tell you what they said a good deal of the time, and therefore they will deny to you that they said some of the things that you know they said. They overreact. They get stuck. They get an idea or a hurt or a behavior goal in mind, and they can't get away from it. They want to have something ahead of them to do, and they remain over-focused on that. Social cues are particularly important, and many of these children and adults miss social cues, so that what's going on around them they're not quite tuned into, and so they make a lot of mistakes. One of the classic ways that this is managed is through being the class clown, and we see this many times, that the kid who's always missing the cues is going to get up and be the center of attention, and that way they don't have to worry about whether or not there are any cues to miss. We see very many times with adults that they have checklists over and over and over again. The problem with a checklist is you have to remember to check the checklist. And so I see over and over again that there's a checklist here and a checklist there, but they haven't gone back and done it. So they end up going back and starting over and over again. The frustrating thing is that they can look at someone else and they can even explain how to do something, and they can follow someone else's execution of it. but they can't execute it themselves. So they end up going back to the beginning and starting over and over and over again. This has a big effect on self-esteem and a sense of not being smart or not being successful. And one of the major questions I get from parents is, well, I don't want my child to have a label because then they'll think there's something wrong with them. Well, what I have to say to you is that these children, adolescents and adults, all already know that there's something wrong with them. They've compared themselves to the person beside them, and they know they're not getting it, they're not doing as well, and many times the conclusion they come to is that they must be stupid because the kid beside them, even though they understand the concept better, the child beside them is actually getting better grades. What does it feel like to have ADD? What's the experience like on the inside of someone? Let's look at the next slide. First of all, what I want you to notice about this slide is that everything is not lined up very nicely, that there's different sizes, there's different colors, and so if you look at this slide, it's very difficult for you to pull it together and read it and stay with it. Now, look at the next slide, which shows all of these same experiences in a very nice order, the way you would expect them on a slide. This is what someone without ADD experiences in their mind. It's organized, it's there, it's not complicated. Now let's go back to the original slide that shows how difficult this slide is to sort of pull together. Now, let's go to the next slide and add another dimension. As you can see, not only is everything in a different size and a different color, but it's whirling around constantly. Now, what would it be like for you if this is what your mind was like all the time, and you were trying to pull all this together and grasp it and give it back to someone? This is what the internal experience is like, and it gives you some idea of how difficult it is for these people when this sort of thing is going on inside their mind over and over and over. So when there's something that you can focus on and stay focused on and it pulls you together, of course you're going to stay with it. It's very important in doing the initial evaluation on people, children, adolescents, to make sure that there's nothing else going on with them. The next slide will show you the different kinds of things that can look like ADD but really aren't. Now, unfortunately, sometimes 3 or 4 of these things are also going on at the same time as ADD. For instance, caffeine is a very common self-medication because it helps you stay on task for a short period of time, as is tobacco. And so it's very common with ADD to find people, and even kids, drinking a lot of caffeine. And you can't say, do you drink coffee? Because it may be Cokes, it may be Jolt. There are a number of different caffeinated drinks, and all the kids know about them. Now, without going into too much detail, let me just again say it's important to have a good physical exam and a good workup to make sure there's nothing else medically going on. A good deal of the time there really isn't, but you must check that out first. So as a parent, what are you going to do if you think your child has attention problems? And many times in today's academic system, you're going to find that these problems show up earlier and earlier. There are some fairly characteristic times, 3rd grade many times, because there's a lot of rote memory and instruction and structure in 1st and 2nd grade. In 3rd grade, kids are asked to do things more sequentially and in steps, and to think some for themselves. And so you have a kid who may do well, and then in 3rd grade, they start having very erratic performance. Another problem that's related to this is the memory issues. It's not long-term memory, it's more short-term memory. So if you think of memory as memory on a computer, we have random memory, which is what you have when you pull something up on the screen and type it in. Now everybody knows at this point, if you don't save that to the hard drive, when you shut the computer down, it's gone. Because all of us, especially those of us who started with computers in the before time, know that when we forgot to save, we lost. And so now the computers automatically save even if the power goes out. But that's short-term memory. Long-term memory is like the hard drive. And what we find in many of these kids is that once it makes it to the hard drive, the information is there. But if you look at it in temporary memory, which is on the screen on the computer, these kids will look at it and go, okay, I think I know it. But since they don't know what they don't know how to study. So they take what's on the screen, they save it to their hard drive, which is the long-term memory. They sit down an exam, and guess what? Some of it made it, and some of it didn't. And they don't know what's going to make it. They can't go, well, I know that. That's easy, I know it. This I don't, and I need to concentrate on that. They look at it, and they think they know it all. And then when they try to recall it, they don't know what's coming out. So it becomes very frustrating because they can't predict success. Another time that is crucial is going into middle school. And the system that we've been in, generally speaking, in middle school, we call it the abyss because kids are supervised at 5th grade. At 6th grade, they're expected to suddenly be organized and suddenly do it all themselves, and parents are supposed to take their hands off. So many times kids who have been very structured, where they've had a parent, usually the mother, who's picked up the slack and spent the 2 hours struggling with them to get 15 minutes worth of homework done, suddenly they're failing out in the 6th grade. Sometimes you can make it all the way through high school, especially if you have a small class or a very highly structured school setting, which many of the private schools provide. And then when the kids get to college, they have no structure and no way of keeping themselves on task, and it's very common to see these kids flunk out the first semester in college. I usually ask parents, if the child is very solidly ADD, not to let them go away from home the first year for college, but to have them spend the first year at home, get the college routine under their belt, and then let them go away. Because otherwise, they're just going to have to come back and we're going to have to start all over again. And I've seen this many, many times. An interesting corollary or add-on to this is that by the time many people reach graduate school, even if they have ADD and they get that far, they have learned how to learn. And so it is very common to find people in a master's or even a doctorate program with ADD who are suddenly making really good grades because they're motivated and they have a goal and they have finally learned how to get around the disability. These are the questions you should ask. They're on your screen. How many patients with ADD or AD/HD have you treated? What type of evaluations of my child will you be conducting? Do you follow a multimodal approach? That means a team approach. Do you recommend parent, child, and teacher training programs? And are you qualified to evaluate my child for coexisting disorders? Just because someone knows what ADD is does not mean that they can sift through depression and anxiety and mood disorders. And so that is a reasonable question. In treatment, and this is a difficult one for most parents, this is really a neurologic disorder, and medication is pretty much the cornerstone of the treatment. It's like wearing glasses and learning to read. If you need glasses, you need to put the glasses on. You still have to do the work, but you can't do the work without your glasses. It's the same with medication. The medication puts the brain into a proper state of functioning so that the child or the adolescent, or in many cases the adult, can do the work that they're capable of. So, if you will look on the screen again, you'll see 3 major points when it comes to treatment. First is the best function, not getting off medications. Many people say to me, I want to get off this medication, that's my goal, and I say that would be wonderful. If we can get there, we'll try to get there. Don't count on it. The best dose and not the least dose. I hear this often, well, let's just put them on a small dose. Well, a small dose is like doing a small dose of an antibiotic. If you don't give the right dose for the right amount of time, it's not going to work. The third point, which I think is is probably the most important point, is that rather than treat a diagnosis, you should treat the behavior or treat the symptoms. So that when someone comes to see me, I'm going to say to them, what symptom or what behavior is the most troubling? And let's see if we can start with that. Most people do not understand that diagnoses are simply convenient ways of passing information back and forth between clinicians. Diagnoses tend to be reductionistic, meaning that people are so varied and so different that trying to put everybody under one heading means that you're going to have a lot of trouble making everyone fit. An example of this is the diagnostic criteria for attention deficit is actually normed for children and adolescents. So the majority of adults are not going to meet the criteria. Again, on your screen, you need to find someone who knows about the disorder. Coaching and tutoring are very important for ADD. Very often, there's a need for individual, family, and marital therapy. These kinds of struggles in children can put a tremendous stress on marriage, particularly if one of the spouses also has the disorder. Medication is important, but diet and exercise also are very important. Exercise helps the precursors for certain neurotransmitters to get into the brain. It doesn't last long, but it helps everything work better. Diet is also important. The main medications that are used are the stimulants. Now, most people think of these as uppers, and it's sort of a paradox that you give a child who's hyperactive something that would make most people hyperactive, and it calms them down. The stimulants help a particular neurotransmitter called dopamine. Dopamine in the brain of people with this problem is not around long enough to do its job properly. So what we do is we take something that helps dopamine to stay around and do its job. Right now, the best thing on the market for that are the stimulants. Now, there's really only two, and most people don't understand that. There's methylphenidate, which you'll see on your screen, and dextroamphetamine. Those are the generic names for the two primary stimulants. Now, oddly enough, methamphetamine is also a legal prescription, but I don't know anyone who prescribes it, and I certainly don't. Now, methylphenidate has a lot of names. The most common one is Ritalin, Focalin, Concerta. These are very familiar names to most people. Methylphenidate is most widely known, dextroamphetamine is most widely known as Adderall. Both of them are equally effective, and for reasons that are not clear, one may work better in one person than another. It is somewhat of a trial and error process in prescribing medication because the protocol has to be tailored to the individual. So some people who are very small take large doses, and some people who are very large take very small doses. The important point is that it is not a dose-related response, that each individual has to take medication and figure out what works for them, and then work with somebody to make sure that they have the right dose. Once the dose is settled out, generally speaking, people will stay on that dose. Interestingly enough, the older you get, the smaller the dose. Because as you get older, you do gain more insight and more ability to compensate somewhat for it, and the requirement for medication may be less. Children don't have anything to lean on many times except the medication. However, it is very rare for someone not to need medication at all if they truly have this diagnosis. When it comes to the other symptoms of attention deficit, hyperactivity, for example, stimulants don't always help this part. And so sometimes you may hear someone recommend something like clonidine, or 10X. These are actually antihypertensives that are somewhat calming. And they are used particularly in younger children to help calm the hyperactive part. What is usually more common is that we find that children and adolescents will have more than one thing going on with them. So if they have depression, or in particular if they have a mood disorder, meaning that they may do fine one day, then they may have meltdowns, they may be short-lived, or they may go for a period of time where they're very irritable, where they're very angry, and then they may settle out. You may also find that they're very depressed. Now, typically in children and adolescents, depression does not present the way it does with adults. Adults many times, not always, but many times will say that they feel sad. They feel unhappy, and it's clear that they know their mood is down. Although many times, particularly in men, what we will find is anger. They won't say they're depressed, although everybody around them can see it. They'll say, I'm angry. And they will feel like whoever is around them is causing anger. With children, and particularly with adolescents, if they can be moving and on the go, they don't have to feel their feelings. So when I was doing inpatient work, many times I would have adolescents say, I was fine till I came in the hospital. Now, how do you say to an adolescent, well, the reason you felt fine is because you're contained and you can't feel your feelings, because that doesn't make sense to them. But as they're in the hospital and they have no way to act out and avoid the feelings, they get unhappier and unhappier, or angrier and angrier. A very common secondary or comorbid diagnosis these days is bipolar disorder. Now, that's also a disorder that has many faces. And you may very well find that a child with ADD and a mood disturbance is called bipolar. There are many of us that think that there is a mood disorder that goes along with ADD many times that is not truly a bipolar disorder. It has a lot of the characteristics of it, and it responds to the same kinds of medications, but it has a much better prognosis. So that when these kids, and I've seen many of them, get into early adulthood, you don't get a classic bipolar or manic depressive presentation where they have up periods and then they have down periods. But it is very common with children, and particularly with children who are started on a stimulant, if they have another disorder, such as depression, or a bipolar or a mood disorder of some sort, to see that aggravated by the stimulant. Now, that doesn't mean that the stimulant is bad. What it means is that you have to go back and get the mood problem under control and then go back and add the stimulant. And that's because there are different parts of the brain that aren't functioning well. Some of them overfunction, some of them underfunction, and that's something we can see now with our neuroimaging studies. So when you look at the brain and you see part of it underfunctioning, you're going to have to do something to raise that. When you see another part of the brain overfunctioning, you're going to have to do something to calm that down. So it's very common these days to find someone on 2 or 3 different medications, and that feels very experimental. It feels a lot like polypharmacy, and parents are very concerned with this, and I think they ask very good questions. But let me reassure you that there is a reason behind choosing different medications. Now, it's the doctor's responsibility to be able to explain to you why you're taking a certain medication in a language that you can understand. If your doctor can't explain it to you in a way that's satisfactory for you, then you need to find someone else. It is very important that you educate yourselves, not only on the disorder, but on the medication and on your child's specific response. One thing I learned the hard way throughout the years is that a mother's gut is right 97% of the time. Now, the way she expresses that is sometimes very difficult to hear, but that doesn't mean that she's not right. Now, she may be wrong about her interpretation, meaning so-and-so does this, my child does this because. But when a mother comes in and says something's just not right, she's always right. You just have to look long enough to find out what it is. So having collateral historians, the mother, other family members, to bring in information and to help give you feedback is very important in monitoring medication, in making a diagnosis, and in seeing whether or not treatment is really effective. There are some very common fears that parents have with stimulants. The first one is that their children will lag behind in growth, that their growth will be stunted. There have been a lot of very good studies on this, and what it shows is that even if there is a lag, that these kids are going to follow their normal growth curve. They will catch up, they will get where they need to be. The question that you have to ask is, what is the risk-benefit ratio? If you have a kid whose appetite is somewhat suppressed and you're concerned about whether or not they're eating, but they are able to function at school, then personally it doesn't make sense to me that you would take the medication away because of the appetite and then let them go back to struggling with schoolwork and peer relationships and everything else in life. Tics are also a common concern. It used to be an absolute contraindication that if someone had a tic disorder, Tourette's being the most widely known, one people are generally familiar with, that you shouldn't give a stimulant. We now know that this is probably not true, that the stimulants can aggravate tics, but they don't cause them, they don't fix them, and again, they don't make them stay for forever. And as time goes on, the side effects really diminish with medications, particularly the stimulants. And so, again, that's a concern and a valid question, but in most cases, it's not a reason for not using medication. Irritability is a very common one. And we do see, particularly as medication is wearing off in the late afternoon, that children can be very irritable and very cranky. Sometimes this is because they haven't eaten during the day, and you have to help them with that. Sometimes, though, it's because there's something else going on. And if it's anything other than mild irritability, then you need to go back and say, what else is it that we're not working with? Could be the depression, could be a mood disorder. But if there's marked irritability, then that's a red flag, not to stop the medication necessarily, but to go back and rethink the process and ask more questions. Another common fear is that it will reduce creativity and that the sense of spontaneity or the person's personality will be suppressed. And I hear that a lot from kids. I had one last week who said that he felt like his personality was suppressed on medication. Having been around long enough, I asked him the question, well, what do your peers think about you on medication? And he says, well, they like me better. So again, there may be a sense of being different, but it may be that other people definitely interact better with them. Again, it goes back to the analogy of putting glasses on. It's not that it takes your personality away. You're actually more yourself when you're on medication than off medication, because the brain is in as close to a normal functional mode as we can get it. It's not over-functioning. Mostly with ADD, it's under-functioning. And so once we get the brain where it's doing what it needs to do, I think we're seeing the true personality. Another common fear is addiction. That if we give children stimulants, that we're going to set them up to get in trouble down the road with drugs and alcohol and that it will be used as a crutch. It is very clear that exactly the opposite is the case. That if you treat ADD, the chances of a child becoming involved with drugs because of the impulsivity or alcohol because of the impulsivity is greatly reduced. There also seems to be a subset of kids that are prone to addiction anyway, but this seems to be a separate issue. And this separate issue needs to be addressed on its own. By and large, though, having treatment is not going to increase any risk of addiction or drug abuse. One of the things I'd like to point out towards the end is that ADD and other problems such as bipolar, OCD, obsessive compulsive disorder, Tourette's, etc. These are all covered under they're legal disabilities. They're covered under the Federal Disabilities Act, and so it's not a matter of whether or not your children are entitled to treatment or not. They are, under the law. And if they're in school or in another setting, even in work settings for adults, there are certain accommodations that need to be made. And so let me reassure you that you're not out on your own when it comes to getting help if you need it. Many school settings and many people misunderstand ADD and they tend to look at it as an excuse, and many times people are not given the help that they need. But you as a parent can be your child's best advocate, and you need to understand how your own child reacts. You need to know what the learning issues are. Sometimes they're learning disabilities, such as math or written expression. Those are very common ones. But you need to know what your own child's particular issues are so that you can help them in the system to get the most help that they can. Now, I'd like to finish by pointing out that people with ADD are not in some separate category, as are any other people with depression or anxiety or obsessiveness or whatever. Everybody has their own baggage, and everybody struggles with different things. There's a very well-known quote by Joe Ansis, and I've found this to be very true over the years, having met and worked with many, many different people. And that is, the only normal people are the ones you don't know very well. So, to recap, let's go over the three primary symptoms of attention regulation disorder: distractibility, impulsivity, and motor restlessness, usually called hyperactivity. Now, for those of you who have been watching this and recognize this in your children or recognize it in yourselves, let me say to you that there is very good news now about treatment and about prognosis. We are much more sophisticated in understanding what this is. We know where in the brain things aren't working right, and we know many things that we can do to help get things on track. There are many, many people now, and especially adults, who are treated very successfully and have had dramatic changes in their sense of personal success and in their perceived success by those that are around them. And so the good news is that we can now do something about it, and we will continue in the future to do better and better.